Hi everyone, thank you for joining us. I'm with Chris Helms this morning, who's a nurse practitioner at Australia's first walk-in centre, which is in Canberra and opened in 2010.
Correct, yeah.
And open to a great deal of publicity, both in the nursing press and nationally across Australia and internationally, because we heard about it as well. Why? What was the big issue and the significance of this clinic?
Well, I mean, just in the fact in itself, and the fact that it's the nation's first government-sponsored nurse-led clinic. I think that when you've got the medical establishment that's traditionally been leading services, I think that when you have something like this that the government is endorsing, I think that first of all that's going to create a lot of fanfare. Also, around the same time that the walk-in centre opened up, there was a great deal happening with the nurse practitioner movement in Australia, and there is the MBS and PBS reforms, which are the pharmaceutical and Medicare reforms, which allowed for nurse practitioners to access the MBS and the PBS.
So MBS, PBS.
The Medicare benefits.
Is that formulary? That's insurance?
That's basically, yes, insurance, of a type, government insurance, I suppose. It allows for government subsidized medications, referrals, equipment, pathology, things like that are subsidized services by the government for the citizens and residents of Australia. So those reforms came about, allowing nurse practitioners to, for the first time, access those items for the benefit of the public.
Right.
And so the walk-in centre opened up, the nation's first nurse-led clinic, and then these reforms occurred around the same time, and that's why it became such a huge deal, is that it was acknowledging for the first time that nurse practitioners and nurses in general have something to add to the table, and that we know that we can provide care that's safe, effective, and is able to be viewed as complementary to that of our medical colleagues.
I mean, the fact it happened in Canberra, which is the capital, was that purely by chance? Because I presume legislation is statewide. There was the way that the walk-in centres were first. The walk-in centre, there's singular, not plural. Sure. The way that occurred was that there was a joint sort of collaboration between the Commonwealth government and the local government, and so this was done as an experiment, if you will. And it was pushed forward by really forward-thinking people that wanted to see nurses working, towards an extended and expanded scope of practice. So, in terms of what can and can't be done within the clinic, the service that you offer, we'll go through that. Is it minor injuries? Is it?
Yep.
I mean, how far can you go, and where are the barriers?
Yeah, I think that was one of the things that was, one of the greatest questions about, what kind of services should we be providing, and I think that. With the ACT Walk-in Centre, we provide acute episodic care for minor illnesses and minor injuries. Well, what is a minor illness? What is a minor injury? I think that, it's sometimes a bit hard to define. I think, you look at things like gastroenteritis, upper respiratory tract infections. You look at perhaps minor lacerations that don't require deep surgical repair. You look at things like non-displaced fractures, for example, are another thing that we provide care for. So that's what we do in the walk-in centre. I think that in the future we'll be looking at different ways of providing nurse-led care as well. Obviously, you talked about things that you can't deal with. There must be a good relationship with other healthcare colleagues where you have to refer on. Was there ever a barrier where they said, well, we're not taking referrals? Is that something you have to build up, or did you emerge and be accepted with healthcare colleagues that you know what I'm saying, where you have to refer on? Absolutely not. I mean, we had some very, very key supporters within the medical community. I think that, for example, the GP liaison for the hospital where we were co-located with was excellent and key and instrumental in the success of the walk-in centres. So we had a few sort of very, very strong general practitioner advocates in the community, but when it came to referrals to other services such as
For example, we wanted to stop a referral to the emergency department from occurring because we knew that it could possibly be sent to the emergency to a general practitioner with appropriate sort of follow up. And when we would call and describe the client, we were just told just send it to the emergency department. We'll make the decision. We'll triage the patient. So there was not a very, very collaborative approach, I feel, towards managing clients in that context. I think that, however, it's changed over the past 2 years. It's actually grown, and the collegial relationship between the services, between GPs and the emergency department, and that comes down to just trust. Is that they were very afraid that we were going to kill somebody, that we were going to hurt someone. And so I think that once they figured out that the care that we provide is excellent, we provide very good holistic care. We're quite thorough with our assessments and our management plans. And I think that after 2 years of showing the community what we can do, I think that there's been a much wider acceptance of the role and of the centre.
What model did you base it on? Because when we've talked before, there is a UK influence.
Yep. Absolutely.
And why not United States influence? Because you're from America.
Yeah, it's a very interesting question, actually. I think that a lot of the model was borrowed, if you will, from the UK. In fact, some of the advisors for the initial project were leaders in the walk-in centres here in the UK. So their input was quite valuable in the design of the Australian context walk-in centre. The reason why, in my opinion, the reason why that the walk-in centres were not modeled after the American walk-in centre.
They have walk-in centres in the States, and suddenly thinking, that is a familiar model.
Yeah, that's the walk-in centre model in the United States. First of all, nurse practitioners in the US operate very differently than nurse practitioners in the UK or Australia. They work to a very much expanded scope. There is also comparatively, there's a lot of restrictions, I think, for nurse practitioners and advanced practitioners in the UK and Australia. Compared to American-based services.
The UK followed America as a model.
Yeah,
they've been around a long time in the States, haven't they?
They've been around since the late 1960s. But I suppose they have a very, very, very well-established model in the United States, and have through lobbying have expanded their roles significantly so that they can function quite independently. I think that there's still a lot of growing that needs to be done in Australia, and I can't speak to the UK, with the nurse practitioner role, and that's going to take time. I mean, I personally think that the nurse practitioner role has grown exponentially fast in Australia. Considering the fact that we've been around for only 10 years in Australia, and now we have our first nurse-led autonomous walk-in centre. I think that's fantastic.
So you have no medical input?
Absolutely none whatsoever. And
how are the public with that? Because over in the UK, when the NHS walk-in centres set up, they had to put leaflets out to say, this is what we offer, this is what we don't offer. We sometimes have general practitioner cover, but generally they don't. And you don't at all.
At all.
So do you get people queuing up saying, hey Chris, I thought I was going to see... Because it's very different, isn't it?
Yeah, it is very different. And I think that, we still get clients that come in every day saying, I'd like to see a doctor, please. And then they're informed that, this is a nurse-led service. And by and large, the response is, oh, all right, fine, that's fine. And I have to say, and this is one of the most exciting things about the nurse-led clinics, at least in Australia, is that I have never, in my entire career as a registered nurse and as a nurse practitioner, worked for a service that had such overwhelming positive response from the community. At our walk-in centre, we've seen over 33,000 clients, and I can probably count the number of complaints on one hand, and then this huge log of compliments and saying, please expand the service. It's really quite exciting that clients are seeing a different way of providing healthcare, and they're really excited about it, and they're really pleased that they feel like they're getting this holistic sort of approach to their problem. So,
do you see clients again?
We try not to. We try to.
I mean, for the same thing.
Yeah, for the same
thing.
thing.
Back to something different, but.
We try not to, because again, the model of care is acute episodic care.
Right.
So what we generally tell people is that, you know, if the condition doesn't improve, it's likely that they're going to need pathology and further diagnostic testing.
Yeah.
We do provide some pathology services, right. And we do, you know, for example, provide imaging services on Mondays or Fridays and during working hours. But those imaging services and those pathology services are quite limited in their scope. And so if you have somebody coming in with, for example, a cough that's, you know, that was initially seen in the Wolkin Center with an upper respiratory tract infection, felt it was just a common cold virus, and, you know, 3 weeks later they come back with this continual cough, and you think, oh, well, is this pertussis, is this whooping cough? And then, you know, they really do need some, you know, further diagnostic testing, and those services we don't typically provide. So we don't. We encourage people to actually go see their GPs, because number one, it enhances collaboration between providers, and it also provides a different perspective on their care, so that it's more holistic. So.
And you're a prescriber?
I am a prescriber. The advanced practice nurses in the Wolkin Center work towards established medication protocols, whereas I have a formulary that I'm given, and I work within that formulary.
So, in terms of what this means for Australia, I mean, it's a groundbreaking service. Are they rolling them out? And it's still early days.
It's still very early days. I think that there's a lot of play there as far as the decision to roll out these centers. I think that initially, the initial discussions around the Wolkin Centers was that it was going to help offload emergency departments. It was going to help create better access for clients. It was give them better choice and assist the general practitioners with reducing their burdens in the community. And about a year ago, there was an evaluation report done on the Wolkin Centers, which was published and is available on the internet. It was performed by an external review source. And it made a few observations about the Wolkin Centers, and first and foremost, that it doesn't really offload emergency departments, which is something that we've known since probably around 2002. So I guess in order for them to roll out, I think that the political climate has to be in the right sort of frame of mind, I suppose. Yes, you're right. But then there also has to be a decision about, well, what do we want these centers to do? You know, do we really want them to offload emergency departments? Well, if we want to do that, then we need to really look at the model of care and say, well, right, instead of, you know, we don't, for example, currently provide IV fluids to clients that assist a minor illness and minor injury center. But if we really want to offload emergency departments, one of the most common presentations you see from, you know, a Category 4, Category 5 presentation is dehydration due to gastroenteritis, for example. So if you really want to look at ways of expanding the scope and the role of the Wolkin Centers, maybe perhaps we should be looking at, you know, the ability to provide IV fluids. So with that in mind, I think that, you know, once we decide what we want these Wolkin Centers to do, then they'll be rolled out, either A, to focus on emergency departments, or B, focus on creating better access in the community. So,
lovely. Thanks very much, Chris.
Thank you very much.